Hello, everyone, and welcome to the conversation. My name is Deborah Holt Noel, and we are so pleased to have you here with us this evening for a very important conversation about mental illness in America. And what's super exciting is that we have a very special guest with us. His name is Dr. Ken Rosenberg, and he is not only an esteemed psychiatrist. He is also a filmmaker and the creator behind the film Bedlam, which aired on UNC TV last night, an incredible, compelling documentary about mental illness and the criminalization of mental illness in America. We are going to get an opportunity to listen to him, to ask questions of him through the chat. And if some of you aren't aware, you can just take a look at the bottom of your window and you'll see a Q&A button. You can just click on that button to submit a question, and we will be able to ask a question of Dr. Rosenberg. We will also have a very special panel of professionals in behavioral and mental health with us this evening from around North Carolina. They're going to be in a panel. You can ask them questions as well. But once again, this is a great opportunity to find out more about mental health in our nation and the critical state of it. Right now, I would like to welcome to the conversation Dr. Ken Rosenberg.
Pleasure to be here, Deborah. Thanks so much. It's an honor, really.
Absolutely. And your film is just incredible. There's a lot of information out there. We know that there are probably families who are dealing with mental illness in their family or perhaps friends. We are going to have resource information for you, and we'll share that on the screen throughout the evening. But first, I just wanted you to share a little bit about your film. As I mentioned, there will be resources, and we'll probably bring those back up again. But Ken, would you just share a little bit about the making of the film? And for those who didn't get an opportunity to see it on UNC TV last night, what's it about?
Well, yes, you can see it's streaming on pbs.org. You can find it in the independent lens slot. The film is about the tragedy and trajectory of people with serious mental illness here in America, and particularly in Los Angeles, which is the epicenter of the crisis. But as you know, in North Carolina and throughout the world, this is, a very common occurrence that we've made having a mental illness, a serious mental illness, a crime. If you have a mental illness, you're 10 times more likely to be in a jail than a hospital. We've made it, so that research has really stalled for people with serious mental illness. There's been a 90% decrease in new trials for schizophrenia drugs in the past 15 years. So I think the film really tries to look at it and provides a very honest look at my profession, psychiatry, which frankly I'm extremely proud of. I love being a psychiatrist. But we've dropped the ball when it comes to serious mental illness, at least in the last century. We're trying to make up for it now. And looks at how our nation has abandoned and neglected our neediest citizens. And it looks at my own life in terms of my sister. I had a sister who passed away, unfortunately, but she had schizophrenia and died at an early age because of her schizophrenia. So we really try to share the stories of serious mental illness and humanize that for people who don't know about it and empower those people who do know about it so we can really change the situation and really start a new conversation.
Well, what you're doing is very, very courageous and brave. You're sharing your personal story and even delving into this issue. Anyone who sees the film understands the enormity of what you are trying to penetrate here. And what we want those who've tuned in this evening to know is that by participating, by being aware, you can make a difference. We want to know if this conversation, if the film that you saw last night impacted you in any way. So we're going to be sharing ways for you to connect to a survey that won't take very long. We really need to hear your feedback. This is part of what Independent Lens is doing, along with PBS and UNC TV. It really helps us to understand the impact of documentaries like this. So Ken, tell me, what have you witnessed in terms of the impact of the documentary as you've shared it in festivals and conversations around the nation?
Well, we were fortunate enough to premiere at the Sundance Film Festival. I'll tell you honestly, Deborah, I was shocked that we got in the Sundance Film Festival. There's 14,000 films that were submitted. But in all seriousness, I was more shocked that we were the first film they could remember showing about serious mental illness. And I think that shows how much we've neglected that conversation. We've had audiences come up to us, and really talk very freely and openly. Wherever I go, there's always someone who says, I have a bipolar disorder, I have schizophrenia, I have a serious mental illness. Help me speak about that, help me share it. And what we've seen is people really want to talk about it and people want to change. I think that we're at a watershed moment now in our country. There's been a lot of neglect in the 20th century, but I do see hope in the 21st century. In the film, we talk about and show the first protests that I ever witnessed or aware of for serious mental illness that happened in Los Angeles, where they built the building of a mental health jail, a jail really for people with mental illness that should be a hospital, not a jail. We've seen a lot of great things happen with the Parity Act in 2010, with the CARES Act and the Cures Act, and a lot of acts that have tried to bring mental health advocacy to the fore. We've seen a lot of hope, but we've seen America is really ready to have this conversation. As I said, I was shocked that Sundance didn't have a film. I was shocked that they had our film, but I was really shocked that they didn't have a film about serious mental illness. But I think the time has come when we're going to see more films and more conversation about something that really is America's great secret and America's great shame.
Well, it definitely has the ability, your film, to be a tool for change. So thank you so much for producing it. Please share with our audience how long it took you to produce this. I think that one of the most amazing things that I found in the film was the story of Patricia Cullors.
Yes, Patrice Cullors, exactly.
Patrice Cullors, thank you, of the Black Lives Matter movement. And you caught her before Black Lives Matter and throughout. Talk a little bit about the duration of the filmmaking.
Yeah, so we started the film. I've made films since I was a medical student. I went into medicine to become a psychiatrist because my sister had schizophrenia, and medical school was really boring in the first 2 years. There was not a whole lot of psychiatry, and my medical school was very, very kind. They let me take filmmaking courses, actually, and even gave me grants to make films. So I've been doing this for a while, but you never know where a film is going to go. We started the film in an emergency room. We picked the busiest emergency room in the country, USC LAC, the county hospital in Los Angeles. And we filmed people, and then when I looked at the footage, I saw there were a few people who I wanted to follow. And that wasn't part of the plan, but I realized very quickly that to tell this story, we had to collaborate with the patients. We had to show their lives over time. And one of the things that we always do is we talk to family members and say, hey, we filmed the patients with HIPAA consents, and the doctors consented, and the patients consented. But we say to the family members, will you be in the film, and can we share your story with our viewers? And one of those family members turned out to be Patrice Cullors. And at the time, she was a young activist. She told me she has plans to be an activist. I was great. I hope something comes of it. But we're going to follow you and your family over the course of several years, if that's okay. And lo and behold, she co-founds Black Lives Matter. She becomes, in the course of the film, 5 years that we follow her, she becomes the country's foremost activist in the area of mental illness and mental health. There's no way you could plan for that. That's kind of the beauty of documentary filmmaking, and many stories emerge like that in the film. Things that we would not expect to happen. One of the things that we didn't expect to happen is that I would put myself in the film and I would talk about my own story. Had no intention whatsoever of doing that, but decided really in the 11th hour, literally the fourth of the year of making this 5-year film, that we had to do that so people knew why they were watching the film. They knew what was behind the film. They had a sense of the filmmaker, not just as me as a psychiatrist, but me as a family member living with it.
Well, I won't spoil it for anyone who hasn't seen, but your story is gripping. Share with us what you see as a success story coming out of the impact of this film. What would you like to see happen?
Well, I think we're seeing it tonight, right? We're having a conversation. We would not have this conversation if the film didn't exist. And I think that that's what we're seeing across America. We have just incredible responses in the press, and I've written op-eds, and we've appeared in everything from the New York Times the Washington Post, the LA Times wrote a wonderful editorial about the film yesterday, which again just blew me away. So I see that we're having a conversation about something that we usually don't talk about. You know, for the better part of the last century and for part of this century, people with serious mental illness hide away, and their families even hide away. I hid away. I didn't talk about my sister's illness till I was, 40 years old, and I didn't really share this story with almost anyone. When my friends see the film, they're like, wow, Ken, we didn't know that. So it's a very hard topic for even myself to talk about. And that's the purpose of the film, to really have the conversation and move the needle so that we no longer neglect people, that we provide them not with jails, but with hospital beds and care that really can make a difference.
Well, you've already made a difference, and we hope that this conversation makes a difference. I want to introduce the rest of our panel that is joining us and remind you also that you can participate in this conversation by asking questions. Click the little Q&A button at the bottom of your screen, and your question is fully anonymous. We just want to know what your questions and comments are. So first, I'd like to introduce and welcome Cody Kinsley, Deputy Secretary for Behavioral Health and Intellectual and Developmental Disabilities for the North Carolina Department of Health and Human Services. We also have Dr. Gary G. Kreitz, Executive Director of NAMI, Inc., and Jessica May, the Director of Development for Western Carolina Rescue Ministries, and Tiffany Ihanaho, Justice Resource Coordinator for Buncombe County Government. Thank you for making time this evening to participate with us. I want to open up with you, Cody. Cody, can you share with us the film Bedlam? It's primarily shot in LA, but it deals with issues that a lot of people around the country are facing: shortage of beds, police as first responders, incarceration, stigma, and shame. How does mental health across North Carolina compare with what is shown in the film Bedlam?
Deborah, thank you for the question, and thank you so much for having me. I believe that the film is a beautiful and quite poignant portrayal of what we're seeing across the nation, and especially here in North Carolina. What we see nationally is that less than 5% of people have a serious mental illness, whereas we know in our homeless population here in North Carolina, 25% of people have a serious mental illness. And those statistics hold nationally, but I know them for sure here in North Carolina as well. And it's the same story in our criminal justice system. We see 60% of people in jails having a mental illness, where only 20% of the general population will experience mental illness in a given year. So that's a factor of 3 that we see over the general population. And I think that kind of looping back to what you said about shame, and to me this really boils down to 2 things, and also drawing from something Dr. Rosenberg said. It's really about the words stigma and with. Stigma in the sense of how do we think about shame and raising awareness and changing the conversation, but how do we also tackle the systemic stigma in changing the way our criminal justice system works, the way our schools work, and the way the employment system works to push people with mental illness out of the mainstream access that they need to survive in our society. And the concept of with, and Dr. Rosenberg said it beautifully, the filmmaking that was with the patients, with the doctors, and with the families. And I believe that we're moving to a model of care. We have an opportunity to work with patients, with their families, to truly achieve recovery that is whole. And that's what I'm looking forward to. And that's what I believe that the movie does such a good job of tackling here, and it's applicable everywhere.
Thank you. And let me hear from you, Tiffany. From police as first responders to jails and prisons, they're serving psychiatric hospitals. How does this play out in your community?
I definitely can echo what Cody stated. And as far as Buncombe County, where I'm located, Asheville is the county seat. Buncombe County has been around at diversion and investing in community mental health for at least 40 years in terms of the criminal justice system. And so we use here something that was created maybe 20 years ago called the sequential intercept model, and that can be found. I believe you guys will have that information shared with you, but it looks at the intercepts of criminal justice points and how to divert people into mental health treatment and behavioral health treatment that need it, starting from crisis services all the way up to corrections and reentry. And so about 2 years ago, we looked at that here locally and determined what resources we do have that will help assist those that end up in our criminal justice system and get them into necessary treatment. We're training our law enforcement and in responding to mental health and substance abuse needs. That's known as the Crisis Intervention Team. It's a national model, and law enforcement is trained in evaluating and assessing mental health crisis, calling mobile crisis if that's needed, diverting them to the emergency room. We have a crisis center and a kind of a one-stop center for mental health, and so law enforcement is able to use that as a resource. And the goal is to connect people early on. Some of our key stakeholders have been discussing a LEAD program here to get people into treatment as opposed to charging them for low-level felony drug possession and just charges related to mental health issues. Our pretrial services offers a specialized caseload for people with mental illness. We have 4 treatment courts centered around substance abuse. Our reentry works with people coming out of prison, getting them connected back to treatment. And there's a whole host of other resources that we we do provide, and the county is committed to stepping up, and it's a national movement to reduce the number of people with mental health in our jails.
And I'd like to thank you so much. I kind of want to move to Jess to talk a little bit about housing. As much as 1/3 of the homeless population has a serious mental illness, what impact do you think housing has on someone's ability to access the resources that they need?
Sure. So I, like Tiffany, am in Asheville, located in Buncombe County. And while it says 1/3 of them suffer from severe mental illness, everyone I have spoken to in preparation for this panel agreed it is much higher. We see a large number of individuals suffering with mental illness, whether it's severe or not as severe, I guess is how I would classify it. And as far as the health care, so we fortunately at our organization have a medical clinic right inside. And so it's easy access for the vulnerable population. It's staffed with a doctor, a nurse, and one other staff member. So they are able to quickly identify and refer them out to other behavioral resources within the community that are great at working with them. But when speaking with my executive director about being on here, one thing he really wanted to push, and it's kind of a different thought process, is we really try to, with the vulnerable population, really love on them, make them feel safe and comfortable. And we have found that building that sense of community through love and support, not judging them for what they have or have not done, is really key. That helps them open up, start to talk about things that they may not feel comfortable talking about. And then through building that, we're able to help get them regulated, get them stable, and then move them into some sort of stability, housing, things like that. I do have 2 quick stories. I'll make it brief because I know we have other people that want to chat. But 2 positive success stories, which makes my job much easier each and every day. We did have a gentleman that frequented our organization at one point in time, and he really believed he was a clown. He put on the makeup, he wore the outfits, he acted the part, and was on the streets doing this each and every day. But we were able to get him the medical care he needed. We gave him that love and support and that stable community, and he is now living on his own. He calls and checks in with us, which is key to building that community. And he is the most articulate man I have ever spoken to. So at the end of the day, these stories are what we at the organization where I work, the Rescue Mission, make it worthwhile. The second one is actually very personal. She would come in very often, was often violent, even a lot of times towards me personally, and very verbally aggressive towards me as well. I, at one point in time, was in the beginning of my career very scared of her. But again, we have loved her through this. We have helped her get regulated and stable. She is on her own, raising her child, has her own place to live. So yay for all this work that's being done. Do we have a long way to go? Absolutely. But I just want to provide a little bit of hope and inspiration for this evening. So thank you, Dr. Rosenberg. This is awesome, and I'm excited to be on here.
Thank you, Jess. And let me go ahead and get you in here, Gary. Now, you shared a little bit earlier that you actually have a personal story with mental illness in your own family. I'd like for you to share a little bit about two words that always come up, shame and stigma, and how those really have impacted our progress in America around mental health.
Thank you, Deborah. As I watched Ken's documentary, I think one of the lines that spoke out to me the most was when Patrice said, shame is dangerous because shame makes you hide things. And when we hide things, we don't get the support that we need. Shame literally kills people. And I think that shame is at the heart of stigma. I see stigma related to mental health issues everywhere. And I think it's always been attached to mental illness. I remember as a child, there were certain things that you could not tell anybody about a family member because to do so would be to be admitting a flaw, to be admitting that there's something wrong with your family. You don't air your dirty laundry in front of other people. And so because of that, an admission of mental illness was seen as a sign of weakness. It's sort of a denial of that stereotypical American idea that, if you just guts it out and be strong, you can get through anything. You don't need help. You can do it on your own. And by doing so, thousands and maybe millions of people haven't got the help that they've deserved. Interestingly enough, though, stigma, while researchers will say that stigma is universally found, people experience stigma in different ways based upon social and cultural things. The way I experience stigma is different than another person. It can be dependent upon race and ethnicity. It can be dependent upon gender. It can be dependent upon religion. As an example, among African Americans, according to whatever study you follow, anywhere from 10 to 20% are more likely to experience serious mental illness, but they're 13% less likely to get the treatment. Now, part of that, the researchers would say, is because of stigma, which is endemic in the community. And I think we see those things in lots of communities. The research is similar with Latinos. Gender seems to play a role in how we perceive stigma. Sadly, I think one of the prime drivers for stigma within our culture are our faith communities. As a practicing Christian, I can't tell you how many times I've heard people say, well, if you're suffering from depression, all you need to do is spend time more with the Lord. You just need to pray more. If you pray more, if you have a better relationship with God, then these problems will go away. We would never say that about physical illness. We would never say, I know that you have a broken leg, and if you just pray more, you won't have to deal with a broken leg anymore. But for some reason, the stigma that attaches is so deeply felt that people that deserve treatment end up not getting it.
You said a mouthful that was really loaded there, Gary, because absolutely in the faith community, you hear this, and it pertains to physical well-being as well. So that stigma can also be masked in the form of protection, I would say. And I wanted to get some feedback from my panelists about protecting the family and protecting the privacy and shielding it from ridicule from the public. It's not necessarily, some would say, that we're ashamed of our brother John, but we don't want others attacking or making him feel bad or attacking our family. Let me hear your response on that, Ken.
Well, Deborah, I think you're absolutely right. the burden for people with serious mental illness falls squarely on the family. Now, it shouldn't be like that, right? I mean, just as police should not be first responders, the family should not be left to figure out how to get treatment, what to do when a patient resists treatment, all those things. And families have shame and they experience denial, but I think your point is extremely well taken. It comes from a place of love. And it comes from a place of wanting to protect the family from the community and from others who would ridicule them. Of course, it's complicated, right? Because it also, that perpetuates the shame when you don't say, this is my story, this is my loved one's story, this is my wife's story, my son's story. By not doing that, you're perpetuating the stigma, which is exactly why I talked about my sister in my film. But I have to say, part of me was like, you don't want to share that. You don't want to talk about your dirty laundry. And I'll share a personal story. When I was making this film, I went to my uncle, who's elderly. My parents had me when they were older. And I went to my uncle. I said, Uncle, I won't say his name, but I said, Uncle, will you be in this film and talk about my sister's mental illness? And he said, your sister never had a mental illness. Now, if you've seen the film, my sister was very, very sick. Fast forward to this afternoon, I spoke to my uncle. He said, I saw your film. I couldn't believe he saw it. I was petrified about him seeing it. He said, I saw your film. In fact, I watched it 3 times, and I'm so proud of you. And he cried. So, shame, as Patrice said, and as Gary, articulated so nicely, and everyone articulated so nicely, shame keeps us a prisoner. And when we free ourselves of that, we could really go places and do things and have, again, the conversation that we Americans need to have.
One of the reasons why we're having this conversation again is to try to help understand better mental illness and how and why it gets criminalized. But before we move on to criminalization, I wanted to talk a little bit more about recognizing the signs. And I think one of the most baffling pieces of your documentary that I saw was the part where there's the mother with the preteen daughter who is at the emergency room or in the doctor's office again because the child is being bullied or having a hard time at school, can't adjust, is threatening and has tried to kill herself. It's figuring out, how do you figure out whether that is mental illness or just this kid needs to figure out how to move through life. The earlier that you catch mental illness, the more successful you'll be at dealing with it. But I was trying to figure out if you could just provide some information about that. I could hear from all of you. Let me open up with you, Cody.
Yeah, I think that it's really hard, and there's been some work done around early interventions, in particular around first episode psychosis, and that's been work that's been in place for several years now that has shown some promise. We know that when individuals, especially that are experiencing schizophrenia or having psychosis episodes, kind of with each moment that they have a crisis, they regress to a point, and getting them back to their baseline is harder. And I'm sure Dr. Rosenberg can speak more eloquently about that. But unfortunately, this tension between stigma and this early intervention is hard. And I want to also say that it's not just about folks putting their hand up and saying, I need help. It's also about having the access in the first place, right? We know that, a large number, more than 40% in some places of psychiatrists work in private practice or in cash-only practice. And we know a lot of folks aren't engaging in the public system where the most serious mental illness is. And unfortunately, we have a society that is designed that keeps people that have mental illness out of work, in poverty, and without health insurance. And while I don't want to divert too far down the path, I will point out that the COVID-19 pandemic right now that we are living with is really highlighting the health inequity that is impacting a lot of people, both of peoples of color and individuals with serious mental illness that are relying on a really fragile safety net system, and the only thing that's left for them outside of the minimal health care that's provided in many places is jail or homelessness. And so that's what's critical about us redesigning a system that really works for folks, so that when they are brave and they can move through that stigma, that there's someone there to truly help.
And Cody, you talk about systems, and I think about the system of education, and that's another place where it seems as though there's so many kids who are they're either misdiagnosed or they're just in these classrooms and they're not getting the help really that they need, and as a result they become this nuisance. And Patrice talks in the documentary about the nuisance thing and what happens with that.
Yeah, absolutely. And unfortunately, a lot of strategies around mental health in schools have been more about metal detectors, right? We've had the conversation about guns as whenever there's an unfortunate tragic event around a school shooting, that it's associated with mental illness, but the investments and the upfront access to care that needs to happen in those spaces to actually give people the support. Again, going back to this concept of with the child, with the family, with the teachers, to truly build resilient and trauma-informed classrooms is not the investments we've been willing to make, and that's where we need to be.
Would anyone else like to respond and talk about how we can better intervene earlier in recognizing mental illness and then getting folks the treatment that they need?
I'll just jump in there, Deborah. I think it's a great question because, it's an interesting question too, because it implies that you have to think really long and hard about taking your child to a psychiatrist or a psychologist or a therapist. If your child said they had a sore throat, you wouldn't say, do I really need to see an internist? If they had a terrible cough, you would rush them to the hospital. I think we need to have the same, care towards mental health as well. If you have a question, see a good psychologist, social worker, psychiatrist, and see what's happening. I think there is such shame and reticence to do that, and I think that we suffer enormously. In my own family, my parents, my sister had, as you know from the film, terrible physical problems because of her mental illness, but my parents sought only to seek help, and my parents were as loving and kind as you could hope for, honestly. But they were victims of stigma. They sought help for her physical problems, but would not ever talk about her mental problems. So I would say to your question, if you think your child might have a problem, talk to a professional. There's no harm in it. There shouldn't be any shame in it. 50% of us, it's well known, need psychiatric care at some point in our lives. 4%, of course, have serious mental illness, but most of us could benefit from seeing someone who we could speak to and explore our psychological issues, just like we have a yearly physical checkup. God forbid we should have a yearly psychological checkup. It's probably not a bad idea.
I would agree. You have to take a mental health break sometimes. And, there's mental health, mental wellness, mental illness. And, there's this long continuum. But I want to pull you into the conversation, Tiffany, to just kind of add a little bit more about dealing with youth. And, what we hear a lot about is the school to prison pipeline. And in the documentary, we were hearing about the criminalization of mental health. So if you put two and two together, I just wanted your feedback on what's happening and how can we help kids who are in the school system who are acting out because maybe they aren't taking their meds because there's the stigma, because there's the cost, factor, what are you seeing and how are you dealing with those kinds of things?
Well, I first will recognize that, in North Carolina, we do recognize that, and our local leaders recognize that as well. And even the state ALC released a toolkit wanting communities to create school to justice partnerships. And so our local chief district court judge, Judge Kavlin Hill, got stakeholders together to really talk about looking and addressing it's the phrase school to justice, but it's really addressing the school to prison pipeline and making sure that teachers have resources to understand what disciplinary actions are needed and do a gradual approach and saving those cases for law enforcement that are high risk and individuals need to be in the juvenile justice system, looking at it from a public safety standpoint. But I think that was one thing that Cody also mentioned about we're so easy to like criminalize youth, and sometimes this is just normal adolescent behavior. And so giving staff the tools, I think cultural competency and working with children of color is also important. Unfortunately, Asheville has one of the highest funding in the state, but also has the highest disparity gap, achievement gap, and disciplinary gap. And so making sure that our communities have the resources and tools to address, and then creating that ongoing and increasing collaboration so that we can work better together to serve our youth. But I think also on the other end of that is recognizing that needing more resources. And so how do we advocate to our state legislators and even our federal government to let them know like the needs in the community are real. A lot of us like Jesse are working boots on the ground, and so it's hard to stretch resources when we have limited, and to make sure that everyone is effectively served. And I want to add too, working in the emergency room for several years, I really empathize with the psychiatrists in the emergency room, just like getting defeated and saying I quit. And for me, it's frustrating because you see people come in crisis and they're coming in repeat crisis after another. And one thing I hear is like the follow-up care is not what they need or desire. And then parents and loved ones call frustrated saying, my loved one needs more than 7 days in the hospital. 7 days isn't enough. The crisis is just over. And so how do we really make sure that we have wraparound services if we're not going to move towards institutions or residential programs, making sure the community has the resources needed to serve people when they're being released from the hospital?
Thank you, Tiffany. Jess, did you want to hop in? Well, actually, before I bring you in, I just want to remind our audience that you have an opportunity to send us your feedback. You also have an opportunity to get resource information. If you'd like to text pound Bedlam to 919-551-7714, that lets us know that you're participating and that you care about this topic. It's really important that we know that you're engaged. And certainly you can click the Q&A button at the bottom and send us your questions. So I would like to hear from you, Jess, in the conversation because you worked so directly with the communities involved.
Yes. So we don't see as many children in our facility that might be needing this sort of diagnosis at this time. I spoke to a doctor in our clinic and she kind of echoed that. She said, it's really hard to diagnose unless they just kind of blatantly come out and say, I'm hearing voices, kind of very obvious signs. But I will say it is hard with our clients because we get them, sometimes they're released from jail or prison, sometimes they're released from a hospital, and they only have about a week's worth of medication. So we quickly have to figure out where that government issued photo ID is, how to make sure that medication is the proper medication and get them that medication, and then pray that they remember what day it is, that they remember what time their follow-up appointment is. So it's very hard to expect them sometimes in the situation that they're in to be able to follow up with those appointments. That's our hardest obstacle, is the follow-up and getting these clients to be healthy enough. It's not that they're choosing not to come. They're just not in a healthy enough state. I mean, they don't have a place to live. They're looking for food. They're having manic episodes. There's so much going on that it's hard to expect them to remember in 7 to 10 days, you need to show back up at 10 a.m. for a follow-up with your doctor. So that's the biggest obstacle we see currently. And if anybody has any great ideas on how we can improve that, we would love to hear from you.
Wow. And that's definitely one of the issues that's brought up in the documentary. I have a comment from our viewers, and everyone just keep in mind that plea that Jess just sent out. So if you have feedback on that comment, feel free to follow up on that. But I just want to share that one of the folks watching says the film was extremely moving. especially as someone who has personally experienced the stigma of mental illness, someone who finally received appropriate treatment, and someone who is now finishing her master's degree in clinical counseling. Yay for you.
Yay.
Following people over the long term really showed a more accurate portrayal of the mental health system, she says, and she wants to know, what can we do to help our own family members stay in treatment? This kind of speaks a little bit to what you were saying, Jess, and how can we help prevent relapse? I'm going to direct this question to you, Gary, and then I'd love for you to weigh in, Ken.
The family is one of the single biggest indicators for long-term health of an individual. Unfortunately, we're limited in what we can do for lots of reasons. I have a family member who suffers from a mental illness that, because she's an adult, I'm very limited. There are certain things that I can do to encourage her to get treatment, but as far as direct intervention, I'm very limited in what I can do. We encourage our people all the time. We have a helpline that's available that we encourage people on a regular basis. What are the specific steps that you need to do? Who are the people that you need to contact? What are the resources that are available within the state? Getting sustained treatment is difficult for all of us, let alone someone with mental illness.
I think Deborah's on mute, but if I could add.
I apologize.
Working with families, I think it's important for when the person's not in crisis or right at that opportune moment, is to understand what the needs of that family member is and kind of work towards that. So identifying and really meeting with your family member and loved one and having a real open and honest conversation, and then find out from them what support that they need and what do they need from you. Sometimes we can be on the other side of the spectrum as overbearing family members and like forceful of, you need treatment, you need to do this, as opposed to really walking side by side with that loved one. So that's just my suggestion and feedback.
Thank you so much, Tiffany. And Ken, I'm sorry, Gary.
One of the things I think that is absolutely critical, and forgive me if I slip into preacher mode at this point, is we need to give our family members a sense of unconditional love. That they are perfect. I love the way Patrice said in the movie, that I think my brother is perfect. She saw him as flawed, but to her, that is the message we need to be communicating, that I love you unconditionally. I love you too much to allow you to go through this pain without me being there beside of you.
And Ken, did you want to respond?
Well, I think what everyone said is absolutely great. I think that it's a very fine line, right? Because you have to both really respect your family member, but also sometimes in the illness, people have what's called a no-signosia, which means that they don't know they're sick, and they actually might even resist treatment because they don't want to participate in treatment. So it's very, very hard. Again, as we said earlier, the burden falls on family members, which I think is really unfair. But above all else, yes, we need to respect the patients. We need to respect those people. There's something I have a book called Bedlam, which preceded the film. And in the book, we talk about something called psychiatric advance directives. And that's when you sit down with your loved one and talk about what to do if they become sick. What they want, what medicines they want, medicines they don't want. Do they, how do they want to be treated? Most people don't want to be strapped down. Most people don't want the police to be called. And I think that, it's really great to, as we did in the film, to collaborate with your family members and talk about, if you become sick, what the heck do we do? Now, that's easily said and not easily done, because when people are sick, you might say, forget about all those things I told you. I don't want anything to do with any treatment whatsoever. So I think that family members have to walk a very fine line, but I couldn't agree more with what the other panelists say, which is basically respect and love, and that's kind of course, the most important ingredient in helping someone get better.
Definitely love and respect. And I just want to say we are just overwhelmed with questions coming in from those of you who are watching. And we're going to get to as many of them as we possibly can. We know that we won't be able to get to all of them. So we are compiling them and will email them out to all of you who have registered for this conversation so that we don't miss anything. And we would very much like for you to take the survey that is provided by Independent Lens. Lets us know the impact of documentaries like Dr. Rosenberg's. He's done such incredible work over the years. He and those who've supported his film need to know that this work mattered. So you can let us know by completing the survey, and you do that by texting 919-551-7714. Text the word #Bedlam to that number, to 919-551-7714, and you can take the survey and make an impact. You can make a true impact by simply taking the survey. We would love it if you would take that step. I want to continue with some more great questions. Let's see, we've got someone here who has asked about evidence-based case management models that focus on basic needs and how important it is to have basic case management services for public mental health. Is there anyone who'd like to take that question?
Sure, I can take that question. And case management is a critical tool to help support folks in achieving daily living goals that they have and navigating not only their own kind of successful choices that they want to make in life, but helping them build the tools that they need to achieve those things, but also, frankly, the complexity of the healthcare system that they often get inundated with, right? I often think about how we take individuals that are unwell and potentially in crisis, and then we throw them into the cobweb of one of the most complicated healthcare systems on the face of the planet and say good luck. And case management and a lot of the work that I'm sure that Tiffany and Jessica do every day is working with people to help them navigate the myriad of pathways that they need to take. In North Carolina, we had case management several years ago. It was removed because of budgetary concerns. And it's something that we've been working on bringing back. I won't bore everyone with stories of Medicaid transformation, but the work that we've been doing to change the way that we deliver healthcare in North Carolina. But a key part of that, something that's been something we're aiming towards, is having that case management work return, because it is really critical for folks navigating systems.
Thank you, Cody. And let's get a question out to you, Gary. People are wanting to know about education and support programs that are available to them. Can you talk a little bit about education and support?
Sure. And NAMI North Carolina is one of a consortium of many agencies around that have evidence-based practices specifically for supporting. One of our prime tools that we have is our helpline. It's not a crisis line. We're not clinicians, but for support and resources, that number is 1-800-451-9682. We also have a number of educational programs that we run that are run by our remarkable affiliates around the state, things like Family to Family, NAMI Basics, peer-to-peer, and so forth. We have specific presentations that are available. We also have just opened a new program just this last week called Thursdays with NAMI. It actually came out of the COVID-19 crisis for us to open up in a web seminar similar to this, where people can come in and spend time and get some basic tools on how do I deal with the stress related to this? How do I maintain my own mental health at this point? What do I do for my family members that are struggling? In addition to NAMI, there are a number of other agencies and our partners around this country and around the state that do very similar programs. Evidence-based programs are the core of what we need in our working with the public.
Thank you very much, Gary. And I have a question. I think this one might be directed to Ken. Jess, or maybe even Tiffany. But let me open up with Ken. We have someone who wants to know if emergency room professionals are equipped and trained to deal with folks coming in who have mental illness.
Well, it depends on the emergency room. I think that, doctors are pretty well trained in this overall. Many hospitals, as the one I filmed in, have psychiatric emergency rooms. There's not that many of those, but psychiatric emergencies are very, very well equipped to deal with this. And it depends on what you mean by well equipped. I mean, because in the emergency room, which I filmed, they had a steady flow of patients, too many patients. They were operating at 200% of their maximum capacity. And that's because they're at the epicenter of the crisis near Skid Row. So by and large, I think emergency workers in general and emergency physicians and nurses are very able to take care of this. But, I think that we want to, as everyone has mentioned, we want to intervene not at stage 4 cancer, to use a cancer analogy, but at stage 0 or stage 1. Unfortunately, with mental illness, we intervene at the latest stage when things are really out of control, when people have to be tied down and injected. We want early intervention at the earliest stages. And so you really help people in a preventative model, in a universal healthcare model, so that everyone gets help as early as possible. But to answer to your question, for the most part, physicians, nurses, social workers who work in emergency rooms are more than capable to deal with this.
Thank you very much, Ken. We have another question that's coming in. Says, it was so sad to watch psychiatric hospitals being torn down in the film. Are any states actually building hospitals that can care for people with mental illness, and just wonder who's getting it right? I would love for, I think maybe Cody, you could weigh in on this as well as Ken.
So it's a great question. And interestingly enough, several months ago, we actually cut the ribbon on a replacement and larger state psychiatric hospital in Western North Carolina in Morganton, which will increase the bed capacity by 85 beds, which is a small number compared to the need. But I think it also ties in back to what Ken was saying, in that, we need to be intervening at earlier stages in this illness, and so that obviously building up inpatient facilities alone is not the answer, right? I loved how the movie looked back at the goal and the commitment that President Kennedy set in shifting more services to the community, and we need to make good on that promise again, right? And that is fully integrated community access to care, and we need to be building that up in the services and supports that people need to live and be successful in the community far more rapidly than we need to be building large inpatient facilities. Of course, it's a balance in everything that we do, but I think the real tragedy is that for the past 30 plus years, we've been neglecting the community-based service.
And here's, we've had so many outstanding questions. And once again, everyone, I want to make you aware that we are gathering the questions and we are compiling them, and we'll put them together in a blog and send them out to you, because we want everyone to be able to get the great information that would come from the answers to these. We have resources that we're going to share at the very close of this conversation, but there is a question out there about how we can work together with departments of health and human services to make sure that there are better accommodations for those who have mental health issues. Is this a question for you, Cody?
I think so, but I'd love to hear everyone else on the panel, their perspective on this as well, because while I have a role around policy setting, I know that the work that's happening up there, especially in North Carolina, the great work that Gary, Jessica, and Tiffany are doing is really on the ground. And I want to make sure that their experiences are really informing the policy that we're trying to shape and the resources that we're trying to bring to bear to help make sure that these services can happen. But, I think it actually just goes back to what I just said, which is, how do we invest in increasing community access to care? Frankly, in North Carolina, Deborah, as you know, of 10 million people in the state, we have 1 million people without health insurance. And last year, I had $280 million from the state to support a safety net for 1 million uninsured people. We served about 100,000 uninsured folks. Easy math, $280 a person. And that doesn't get you much care or get you very far with just that. And so we need to do better to close the coverage gap and expand Medicaid. That's a key priority for us. That's where the resources can be to actually get folks coverage and get them the care that they need.
Gary, let me pull you into the conversation to respond about working with Department of Health and Human Services to help meet needs.
DHHS is just an incredibly valuable partner. And I think what a lot of people don't realize on the ground is that the people that are in the mental health division are passionate about the field. I'm a firm believer that on the systemic level, there are certain things that we have to do, not only with the division, but just in general in our state and even in the culture at large. For one thing, we have to continue to work towards parity between mental illness and physical illness, not only in funding, but in the way we treat it in our society. We have to start realizing the social determinants that lend themselves to mental health or don't lend themselves to mental health. There are certain things such as adequate housing, not only housing in general, but adequate housing for the homeless, things like access to care, things like access to basic medications. These things are not simply basic necessities. I think in a civilized culture, they should be seen as fundamental human rights. And we will never make any headway until we start addressing some of those social determinants.
Oh, that is key. The social determinants of health, that's beyond, I don't even want to call it a buzzword, but it's so key. Final comments from Jessica May.
Yes, I would agree. DHHS is great. We work with them often. We get a lot of good support from them, but we do need the housing. The problem we find is sometimes our clients don't feel like that housing is safe. So again, that's another form of trauma for them or could be a trigger for them. So if we could provide housing that was safe and very communal and loving and supportive, I think we would see a bigger transformation among the population that we serve in particular. In fact, I know several years ago, our executive director was able to meet with people in the county and say, hey, push our people up to the top of the list. Let's get them housing. And they didn't want to go. They were scared to death. They feared for their lives. And we had so much backlash just from in their behavior and their moods and everything because of this huge fear that it wasn't a safe place for them. So I think that's a key thing to remember is, yes, they absolutely need housing and they do need all these basic necessities, but we want to make sure they feel safe in that because otherwise we're just going to see this cycle continue on and on.
Thank you, Jess. Tiffany, what is a lasting thought that you think you really want people to carry away with them from this film and from this conversation?
So what has lasted with me and something that resonated that Jesse said is, we often use this term that the client is treatment resistant, but have we ever framed that to say that our treatments may be client resistant? And how do we better bridge and partner with clients to be a part of their treatment process and not necessarily think that we're always the experts and ensure that we can walk alongside them and have adequate resources in the community to support people to live in the community? Thank you.
Sorry, if I may, I just want to interject because I think there's an important piece here. I so agree with what Tiffany said and peer support, folks that have walked the walk and experienced life. And we're having so much success as an evidence-based model of giving peers to help them work with individuals. That's a really powerful tool I don't think we've quite touched on. I think that that's also key to not only increasing capacity in communities, but to giving individuals with that lived experience, a roadmap to also their own economic independence in working with individuals. It can be a really powerful tool that we're doing more in North Carolina.
I should have given credit. A peer is the one who gave me that framing.
Thanks, both of you. And Ken, I'm going to give you the very last word in the conversation. Just share with us anything that you've seen that gives you hope.
This conversation gives me hope. And I can't, again, tell you how grateful I am. You can get more information about our film and about PBS at bedlamfilm.com. And if you call into that number, we'll get some feedback about how we're educating people, which is really useful, that audience feedback number. Please text it. You know, it's a blessing really to be able to do this. So thank you so much.
Thank you for taking the time and bringing this issue to the forefront in such a compelling way through the documentary. And as you can see, viewers, there are resources on your screen, so perhaps you or someone you know can utilize any of these resources: National Suicide Prevention Lifeline, NAMI, Crisis Solutions, North Carolina. And once again, it is very important that we know whether or not the film Bedlam and this conversation made a difference for you. We would love to hear back from you and have you fill out the survey. The way that you can do that is by just texting hashtag Bedlam to the number 919-551-7714. You can also go online to bedlamfeedback.com. And I would just like to thank each and every one of our panelists, Cody Kinsley, Dr. Gary Kreitz, Jessica May, and Tiffany Ihanaho, as well as Dr. Ken Rosenberg. And I think I might have skipped Jessica May. Thanks to each of you for your time and for the incredible work that you do. Have a great evening. Thanks all of you for joining this Zoom conversation. We appreciate it. On behalf of UNC TV, I'm Deborah Holt Noel. Thanks everyone. Have a good night.